So we are talking about the pharmacology of hypertension. The first thing we need to know what hypertension is. So we define hypertension as a sustained uh, s- systolic blood pressure of at least 140 or a sustained diastolic blood pressure of at least 90. If we say sustained, we mean that you take two separate readings of the blood pressure at least 4 hours apart. Okay, and each one of them is giving you a blood pressure of at least greater than 140 over 90. That is what we call someone has got hypertension. It is a common problem and is normally asymptomatic until late, so it is a silent killer. It will kill someone without any pain. In the early stages of hypertension, there are a few or no symptoms. Complications are yet to diagnosis, but the complications end up coming late. So hypertension is an important factor which contributes in the development of a lot of different conditions like heart disease, cardiac hypertrophy, aortic dissection, cerebrovascular accident or stroke, congestive heart failure, renal failure, and retinopathies. So they can actually ask you how heart failure can come about because of hypertension. So there are different risk factors for someone getting to have hypertension, including hereditary, like a family history or genetics, gender, and also age, like the men and the postmenopausal women are more likely to have it. And then heavy alcohol consumption, having comorbidities, other conditions like diabetes, a diet that is rich in sodium, because sodium, where sodium goes, water also goes there. So if there's too much fluid in the body, that is what causes hypertension. Obesity also results in hypertension. Okay, this is where someone has a sedentary lifestyle, like they are inactive, they don't exercise, and then also the use of oral contraceptive pills, and also race, especially the African. Now, hypertension can be classified into two main categories. You have got according to the cause and according to the clinical features. According to the cause, you have got primary, also known as essential hypertension, which is idiopathic because we don't know the cause, or it can be secondary. So the majority is the essential hypertension. And then looking at clinical features, you can classify as benign or malignant. So there is primary or essential hypertension is unknown how it happens. In majority of the cases, someone is hypertensive. We don't know how it has come about. And then the secondary is due to pathology in different systems like the kidney, the endocrine, the vascular, or neurologic. The endocrine, some of the things that can cause hypertension, secondary hypertension, includes adrenocortical hyperfunction. For example, if someone has got Cushing syndrome, where there is too much cortisol, or primary aldosteronism, congenital adrenal hyperplasia. Okay, so all these conditions, and also there can be exogenous hormones, for example, glucocorticoids, estrogen, including also pregnancy induced and oral contraceptives, sympathomimetics, and also tyramine containing foods, monoamine oxidase inhibitors. All these guys can actually contribute to having hypertension. So when you are taking a history, you also want to someone has got hypertension, you can also ask them about their drug history. Also, if your chromocytoma, this is a tumor of the adrenal gland that secretes a lot of uh, so from the chromaffin cells, there's going to be the release of these. What is the specific name of the hormone? Okay, in the adrenal medulla, you have got the C cells, the adrenal gland has got the medulla and the cortex, but the medulla itself releases the noradrenaline and adrenaline. So in a pheochromocytoma, there is a release of these hormones which are actually sympathetic in nature, and so they get to stimulate the body. And also acromegaly, hypothyroidism, hyperthyroidism, and pregnancy induced, like preeclampsia. Preeclampsia is a very, very bad condition. It's actually an obstetric emergency. It's obstetric because it's in a pregnant woman. It's an emergency. Okay. And also renal causes of secondary hypertension includes acute glomerulonephritis, chronic renal disease, adult polycystic disease, renal artery stenosis, renal vasculitis, renin producing tumor. Cardiovascular, you have got coarctation of the aorta, vasculitis, increased intravascular volume, increased cardiac output, rigidity of the aorta. And then neurological, have got psychogenic, increased intracranial pressure, sleep apnea, acute stress, including also surgery. So classification based on clinical features, you have got the benign and the malignant. Benign, this is a BP that is at a modest level, it's not very high, and it could be idiopathic. You don't know the cause, or it can be secondary hypertension, one of those causes from different systems. So it's actually stable over the years to decades, like you've been with it for long. This is where someone says, "Is this patient is a non-hypertensive? They've been hypertensive for long, so it's compatible with life." Now, the malignant one, there is rapidly rising BP, which often leads to an end organ damage. So, it can be a complication of any type of hypertension, like the primary or secondary. And they seen in not majority, a lot of hypertensive patients, only in a few, like 5%. The diastolic pressure is usually over 120. So it is associated with kidney, retinal, brain, and heart conditions. So there will be widespread arterial necrosis and thrombosis, rapid development of renal failure, retinal hemorrhage, hypertensive encephalopathy, left ventricular failure. So you can say it is leading to other problems. Okay, basically there is end organ damage. The organs of interest, you have got the kidney, the retina, the brain, and the heart. So it can lead to death within 1 to 2 years if untreated. So when you're understanding the heart hypertension, you need to understand BP. So BP is given by peripheral resistance times cardiac output. Peripheral resistance is the resistance of the arteries to the flow of blood. As the arteries constrict, the resistance increases, and as they dilate, the resistance decreases. And then cardiac output is just basically how much the body is pumping out, the heart is pumping out of its chambers to the rest of the body, and is affected by blood volume and is dependent on sodium concentration. So cardiac output is actually given by stroke volume times heart rate. Stroke volume is you have got the number of beats per the amount of blood that is going to be pumped in each beat, stroke volume, and then the heart rate is the number of beats per minute. So peripheral resistance is going to be regulated by the level at the level of the arterioles. Okay. And what determines peripheral resistance? You have got the autonomic activity. So the sympathetic activity constrict peripheral arteries. Okay. When someone is running, that is sympathetic, the peripheral arteries are going to constrict. You want blood to go to the main organs because you are under stress at this point. And then pharmacologic agents can also cause vasoconstriction, like the drugs, and which we call vasodilators. And then blood viscosity, when there is increased viscosity, that can also increase resistance. So the way we regulate, the body regulates blood pressure, there is a normal BP is going to be maintained by a balance between the vasoconstrictors and vasodilatation. So vasoconstriction, you have got things that promote it, like angiotensin 2 and the catecholamines. So catecholamines, okay, this is basically the substances that are involved in the sympathetic nervous system. And then the vasodilators, dilatation, you have got kinins, prostaglandins, nitric oxide. Take note of nitric oxide and prostaglandins here. So remember what we said earlier, that blood pressure is cardiac output times peripheral resistance, and cardiac output you look at stroke volume and heart rate. So what are some of the things that can affect cardiac output? So blood volume can be affected by different things like sodium, mineralocorticoids. Remember, these are the potassium sparing diuretics, arterioretic peptides, and then you have got cardiac factors that can affect cardiac output, like the heart rate and contractility. For peripheral resistance, you have got the constrictors and dilators. Constrictors include those that are hormonal and those that are neuro. The hormonal ones, you have got angiotensin 2, catecholamines, thromboxanes, leukotrienes, endothelin. And then the constrictors, you have got alpha adrenergic receptors. These will be able to constrict the vessels. And then for the dilators, we've got prostaglandins, kinins, and nitric oxide for the hormones, and then beta adrenergic for the neuron. So this is important for you to understand, because if you want to treat someone that has hypertension, you look at the dilators. So beta adrenergic receptor drugs, which work on these receptors, what will be helping in the condition, because these are dilators, so they'll be able to dilate the vessels. And then the drugs that can inhibit alpha adrenergic, which are constrictors, can also help in the condition. So drugs that will promote or increase nitric oxide and prostaglandins can be used in the treatment of hypertension. And drugs that will be able to reduce angiotensin 2, catecholamines, thromboxane, leukotrienes, endothelin will be used to treat. You also have drugs that can decrease sodium, mineralocorticoid, and these ones. Drugs that can reduce heart rate, contractility can also be used. You can also have local factors that increase peripheral resistance, like autoregulation, pH, and hypoxia. Okay. So how does really hypertension come about? So you can see here is the heart here. Now the heart muscle can release what we call atrial natriuretic peptide, and once that is released, it can go to the blood vessels and cause vasodilatation. Okay, and then it can as well go to the kidney to cause excretion of sodium and water. And when this happens, what happens is that there's going to be a reduction in blood pressure. So atrial natriuretic peptide ANP is what the body tries to produce in order to help if it has got an elevated blood pressure. And you can see it acts on two things, the blood vessel and the kidney, to cause the release of water. So that's a normal balance. But sometimes there can be a problem. Okay. So when there is low volume or low resistance renal artery stenosis, like when you have got a low blood pressure, it means that only little blood will go to the kidney, and when that happens, it is going to stimulate the kidney to produce renin. When renin is produced, it will convert angiotensinogen, which comes from the liver, to angiotensin 1. Angiotensin 1 will go to the lungs, and be converted to angiotensin 2 using the angiotensin converting enzyme that comes from the lungs. Angiotensin 2 has got effects of increasing blood pressure. Okay, for example, angiotensin 2 can go to the adrenal gland to cause the release of aldosterone, which causes the reabsorption of salt, and that increases blood pressure. Angiotensin 2 also is going to cause vasoconstriction itself, that increases blood pressure. Angiotensin 2 again also induces thirst. So you feel thirst, you drink a lot of water, and that raises blood pressure. Okay, so we've talked about the effect of that, and you can see also the pathway here. So what are the complications of heart failure? If someone that has got heart failure, on the heart you can have left ventricular cardiac hypertrophy and coronary artery disease, aortic dissection. On the eye they can be hypertensive retinopathy, someone that has got hypertension and then they start saying, well, especially in malignant hypertension. Okay. On the kidney, it can lead to benign. Sorry. So on the kidney, they can be benign nephrosclerosis, and then on the brain, they can be hemorrhage, right? And then that is a general pathology of heart failure. So the next that we have to understand is now the classification, not of heart failure, but of hypertension. The drugs that we use in the management of hypertensive disorders. You have got the diuretics to basically reduce the fluid volume. You have got the RAS, renin-angiotensin-angiotensinogen system. You have got calcium channel blockers, vasodilators, and then the drugs acting on the sympathetic nervous system. So for the diuretics, you have got the thiazides, the loop diuretics, the potassium sparing, and we've just from discussing the diuretics, so we'll not waste time on them. And then for the RAS, the renin-angiotensin or aldosterone system, you have got those drugs that act on angiotensin converting enzyme to inhibit it. So you have got drugs like captopril, enalapril, lisinopril, they end in pril. Especially you see if you go on the word more, enalapril. This one inhibits the angiotensin converting enzyme. And then you have got the blockers of AT1 receptor, alpha T1 receptor. So this one end in Saturn, low Saturn, valsartan. So those are the drugs. So for the angiotensin converting enzyme inhibitors, these ones will decrease angiotensin 2, which causes vasoconstriction. So if there's no vasoconstriction, there will be vasodilatation, and that can help in hypertension, because the problem in hypertension is that there's actually vasoconstriction. Okay. And then the uses, they can be used to treat essential hypertension, hypertension in patients with chronic renal disease, ischemic heart disease, and diabetes. The adverse drug reactions, one thing you need to know about them is that they cause a cough. So if you are clicking someone, you are taking history on someone that is hypertensive, and then they tell you that they also have this cough, try to ask them the drug that they are taking. They might take you they are taking say enalapril. You so you'll be able to tell, because that's one side effect that these patients are going to have. Now, the contraindication, one big contraindication for these drugs is that you don't use them in pregnancy. And then for the angiotensin receptor blockers, you have got losartan, valsartan, and these others. So they selectively block at AT1 receptor. They have got no effect on bradykinin. They have got no cough and no angioedema. They really don't cause this edema. Okay. So they're a bit better. You also have the calcium channel blockers, and this one also came in last year's exam. So calcium channel blockers, they can be classified. You have got the drug, you have got verapamil, nifedipine. Nifedipine is a very good drug. It's actually used in pregnancy because it has no bad effect. And then you also have diltiazem. So verapamil is a phenylacylamine. Nifedipine is dihydropyridine. That is a class. And then diltiazem is a benzothiazepam. But take note that nifedipine is a good drug. You can also use it in pregnancy. It acts more on smooth muscles and and then for verapamil acts mainly on myocardium. Mechanism of action is that these drugs will block the influx of calcium through calcium channel, because they block calcium channel, and that will, will cause peripheral vasodilatation and decrease cardiac contractility. Okay, so this is the alpha 1 receptor that we are talking about that you'll be able to block. One side effect is that these guys will result in ankle edema, especially the verapamil is the one that will cause ankle edema. For nifedipine, it can result in tachycardia, the heart racing very fast. Okay. And then there also be headache, flushing. They can result in hypotension because you're using them to treat hypertension. Vasodilators, these ones are classified into arterial and venous or mixed vasodilators. You have got drugs like adralazine, minoxidil. Adralazine is an important one. It's actually also given in pregnancy. Okay. So how they work, these guys, is that the vasodilators will produce relaxation of vascular smooth muscles. They'll cause relaxation. How? They will decrease resistance and decrease blood pressure. Okay, so when they cause relaxation of the smooth muscles, they are going to result in decreased resistance and decreased pressure. Okay, blood pressure. And then another way by which they get to work is that they have got they increase plasma renin concentration, which results in sodium and water retention. If there's a retention of these two guys, these and this, so yeah, there's going to be retention of sodium and also water. Now, this is not one thing that you want, because if there is a retention of sodium and water, is that they can actually increase and worsen the hypertension. So this is an undesirable side effect which can be blocked by using these drugs together with diuretics and beta blockers. So examples of drugs here, I've got hydralazine, especially hydralazine. Please take note of it because it's a common drug that is used on the ward. And it can actually be used in women that are pregnant. So hypertension in pregnancy, adrenaline is used. And then you also have beta blockers like propranolol, atenolol, metoprolol. There is also labetalol. Labetalol is actually used also in pregnancy, but it's not part of this list here. Okay, so propranolol is non-selective, atenolol and metoprolol, these ones are selective beta 1 blockers. Now, when you want to stop taking these drugs, you should stop them little by little, gradually, and not just stop there and then. They will be able. The way they work is that they have got a centrally acting mechanism. They inhibit norepinephrine release from adrenergic nerves. They can result in hypoglycemia because they can block receptors on the liver. They can aggravate peripheral arterial disease. They can mask hypoglycemia symptoms in diabetes. So basically, don't use them in diabetes. The alpha adrenoceptor blockers like prazosin and doxazosin. Prazosin is short acting. Doxazosin is long acting. For these drugs, the mechanism of action is that they will block alpha 1 receptor in arterial and venues, and that will reduce blood pressure. Okay. Remember, for the sympathetic alpha 1, these are sympathetic. But if it is a blocker, it means that it's acting like the parasympathetic. It will end up dilating the vessels. And then the adverse reaction is that at first dose it can result in hypotension and also posterior hypotension. You also have those that are centrally acting sympatholytic drugs. A common one you need to know is alpha methyl dopa, which is also used in pregnant women. Okay, these and also clonidine. These ones act indirectly. Clonidine is a direct alpha 2 agonist, but methyl dopa is an indirect alpha 2 agonist, which it's converted to methylnorepinephrine. The mechanism of action is that it will diminish central adrenergic outflow from the central nervous system and increase parasympathetic outflow to the heart. So they will increase parasympathetic. And parasympathetic doesn't make the heart to contract more, okay, to contract more, and that leads to reduce total peripheral resistance and decrease blood pressure. So you use them for hypertension. Methyl dopa, again, you use them in pregnancy. Adverse drug reaction, abrupt sudden withdrawal of clonidine can lead to rebound hypertension. So don't just stop this drastically. Okay. So it's important to understand that.